Hello, everyone, and welcome to Community Birth Education, your guide to out-of-hospital pregnancy, birth, and postpartum. My name is Rachel Cunningham, and I'll be your instructor for this series. I'm a two-labor trained birth doula, a mom of three, and a birth assistant in the Michiana area. So let's take a look and see what we'll be covering in this series. So in this class, in this series, we're going to break it up into 4 different classes. The first class, today's class, will cover pregnancy anatomy, nutrition, and informed care and how to choose your birth team. Class 2 will go over how labor works, so the different phases of labor and comfort measures that you can use during each phase of labor. In class 3, we're going to cover physiological pushing, the immediate postpartum, and variations of normal and how we handle those situations in the out-of-hospital setting. And then class 4 will focus on postpartum and breastfeeding. So before we begin today's lesson, I'd like to reflect on how you came to be here. What made you want to have an out-of-hospital birth? What is it that draws you to a birth center or to have a home birth with a midwife? And what events in your life have shaped your knowledge and your view of birth? Do you have an extensive knowledge of birth? Have you seen animals give birth? Have you been there for friends or family as they give birth? And how is that impacting the decisions that you're making moving forward? The way that we see the world shapes the way we birth as well. Sometimes that means that we have a clear understanding of what we want, and sometimes that means we need to learn about the things that we want if we do want a physiological birth. So reflect on those things as we move forward. We're going to go through a lot of facts and figures, and we're going to go through a lot of the scientific process of birth, but just know that it also has a lot to do with your instincts, your surroundings, and what you're familiar with. So like I said, today will be class 1, and we'll be doing pregnancy anatomy, nutrition, and informed care. So settle in, wear something comfy, and let's get started. So I'd like to read this quote by Hannah Dahlen. A woman's birth experience is not something that just happens to her and then it's over. A woman's birth experience is about who she is. It's about who she becomes. It defines her, it unmakes her, it remakes her, it unravels her, and it puts her back together again. The birth experience, like I said, we're going to go through the facts. We're going to go through the phases of labor, the stages of labor. I'm going to teach you all about physiological labor, but so much of it also is an emotional event, an emotional transformation for a woman and a partner that they're going to go through during this time. So just know that although we'll be covering a lot of the right brain things in this class, the left brain is a huge part of this equation, and really following your instincts is really key to physiological birth. Also, it's really important to note that just like the quote says, birth lasts, and it lasts for a lifetime. It impacts the way that you feel about yourself. It impacts the way that you feel about your birth process, about your team. It impacts the way that you parent your child, and that in turn impacts the way that they go out and are in the world. So birth really does have the opportunity to change the world and to change the way that people interact with each other. And wouldn't it be beautiful if we could have physiological birth where a mother feels empowered in her own decisions and really takes charge of her own birth? And how could that affect our society in general as we move forward? So keep that in mind. We're going to be going over a lot of the fact type things, but just know that this process is so much more than that. All right, who's feeling good about their birth anatomy, their pregnancy anatomy, their reproductive anatomy? Because we are going to get into it. All right, so here you have a diagram of the female reproductive organs. Women are born with about 300,000 eggs. They're born with all of the eggs that they'll have in their lifetime, and about 300 to 400 of those eggs will actually be released during sexual maturity. A really fun fact is that if you are carrying a girl, if you know what you're having, you could be potentially carrying your grandchildren because, like I said, all of the eggs that you have, you are born with. So it's very possible that the baby girl inside of you would be carrying your grandchildren in the future. The typical pregnancy lasts anywhere between 38 to 42 weeks, and it's divided into 3 trimesters of about 3 months each. Pregnancy begins with an egg being released from the ovary. If there's a presence of sperm in the fallopian tube, it will embed itself into the egg and become a zygote, traveling down the fallopian tube and dividing as it travels. It then enters the uterus and implants itself on the uterine wall, creating an embryo, and it's the first signs of our placenta. Your placenta is actually attached to your uterine wall, so it doesn't move. It stays in one spot through your pregnancy, although we'll talk about how it can be a little sneaky later. The second trimester starts at week 13 and lasts until week 27, and the fetus will double in size during that time. You may also begin to feel your baby move. Hearing develops around week 18, and the baby will not respond to noises outside of the womb until about week 25. The third trimester are weeks 28 until you have a baby, so 28 to about 40 weeks or so. And this is the time for the final touches, such as eyelashes and taste buds. With most of the major organs complete, the baby will gain about half a pound a week in the third trimester. Most of the baby's bones are developed and hardened by this time, but the skull still remains relatively soft to ease in the birthing process. In fact, your baby's head, as it moves down the birth canal, may very well be born with sort of a cone-shaped head. My baby certainly was. Fear not, if you see that in your baby when they're born, it does go back to normal within a few hours after birth. As you can see in the diagram, the baby will first pass through the cervix when we're in labor. The baby will pass down through the cervix and then through the vagina to be born. During labor, the cervix thins and opens over baby's head to make room for delivery. Before labor, this cervix contains what's called a mucus plug that keeps the baby safe from infection by creating a barrier between the vagina and the uterus. And we'll see that more on the next slide. All right, so in this diagram, we have a non-pregnant body and a pregnant body at full term. So just kind of take a look to familiarize yourself with some of these things. As you can see in the cervical area, you can see that there is a mucus plug that we talked about in the last slide. You can see the placenta that the baby is nuzzled up into and the umbilical cord. Also take notice of how the organs have shifted. Things like the lungs, the bladder, the rectum, all of those things are being compacted. The uterus grows from the size of a pear prior to pregnancy to the size of a watermelon, and organs are compacted like the stomach, lungs, bladder, rectum. So that is another reason why it's important to try to keep your bladder as empty as possible during labor. We definitely want you taking in fluids and staying hydrated during labor. It is, after all, a marathon that you'll be running during labor. But we also want to try to keep the bladder empty as well to make lots of room for baby's head. This is also the reason why a lot of women will report that it feels like they have to have a bowel movement as their baby moves down in labor. And usually we're like, that's probably your baby, because your baby's head will be pressing on your rectum, pressing on your bladder during delivery. The blood volume is increased about 50% during pregnancy. Amniotic fluid surrounds the baby, providing cushioning and equalizing pressure. That's that purple area around the baby in this diagram. That would all be filled with amniotic fluid. The amniotic sac is comprised of 2 layers and is another barrier from infection for baby and keeps all of the amniotic fluid and placenta in. So your baby is protected in 2 ways from infection from the outside world: the mucus plug at the cervix and then the amniotic sac inside of the uterus. If and when your water breaks, it is the amniotic sac that is breaking or leaking. And we'll talk more about waters opening in class 2, but just know that it can look many different ways when your water breaks, and your water can break before labor, it can break during labor, or you can have something called an en-caul birth. And that is where the amniotic sac doesn't break during labor and your baby is born en-caul, so inside of the amniotic sac, and then we open up the amniotic sac and have a baby. That does not happen very often. It is quite rare, but it does sometimes happen. The placenta supplies all of the oxygen and nutrients, filters waste products from baby, and is the source for hormones needed to sustain pregnancy. You can see in this diagram, the placenta is on the front side of the uterus, what we call an anterior placenta. That's actually not the most common type of placenta location that we see. Usually we see a placenta on the back side or the posterior side of the uterus. However, this is just a variation of normal. Sometimes when you have an anterior placenta, you may not feel baby kick or move as soon as others, and your provider may have a little bit harder time like finding baby's heartbeat because of the placenta right there, but it is totally normal and just a different variation. There are a few other ways that your placenta can be presented in the uterus. There's something called placenta previa. So that is when your placenta is growing very close or over the cervical opening. Remember how I talked about sometimes that placenta is sneaky? So the placenta doesn't move, it's attached to the uterine wall, but sometimes if we have a placenta that's very close to the cervical opening, the stretching of the uterus as your baby grows moves, it's not actually moving, but stretches your placenta far enough away from the cervix that a vaginal delivery is possible. Sometimes with placenta previa, the placenta stays over the cervical opening and we cannot have a baby through a placenta. So that requires a surgical birth or a cesarean section. Another variation of placenta growth that's abnormal is something called placenta accreta. So this is where your placenta actually grows outside of the uterus and outside typically of like a scar. So those who have had a prior cesarean are more likely to have placenta accreta, where the placenta grows outside of their scar. This is a very rare thing that happens, but just know that your increased likelihood of having it with a birth after a cesarean, with a pregnancy after a cesarean birth, but those numbers are low. The umbilical cord, you can see there, transfers nutrients, oxygen, and fetal waste products between the baby and placenta, as well as hormones. That's kind of what kickstarts our labor, and averages about 22 inches long. Okay, so this is a slide on the clitoris. It's just here to show you what a clitoris actually looks like. A clitoris is so much more than just the nub at the top of the labia. As you can see on the diagram on the right-hand side, our entire clitoris actually surrounds our vaginal opening and surrounds our labia majora. Something to consider when we think about things like episiotomies or tearing, that we want to try and protect the clitoris and protect those things and keep them intact. An episiotomy is where a provider actually makes a cut either at the bottom of the perineum, so that's the bottom side of the vaginal opening, to allow baby to be born, or to the side. It's usually seen in hospital. Episiotomy rates for out-of-hospital birth are very low. Studies have shown that letting a woman tear on their own is actually much more beneficial than cutting an episiotomy for baby. But it's something to definitely talk to your provider about. You'll want to know and ask, what are your episiotomy rates? How many times have you done an episiotomy in the last month? And really talk to them about what that would look like in their practice. And we'll talk more about episiotomies and tearing in class 3. All right, let's talk a little bit about the hormones that are working with us during pregnancy and labor. So estrogen levels increase and cause the uterus to be more sensitive to oxygen. Oxytocin is the big one that we hear in pregnancy and birth, the love hormone. And this hormone is released by the mother and signals the uterus to contract. So that's what creates our contractions, is that hormone oxytocin. And it plays a role also in bonding and is released during breastfeeding and sexual activity, which is why it's called the love hormone. It's probably what got you here. Prostaglandins, they aren't actually a hormone, but they're very important, and they cause the cervix to soften or ripen and allow it to stretch and open. And we'll talk about that when we talk about cervical effacement on the next slide. Prostaglandins can be found in semen, so sometimes they can be helpful when we are trying to thin and efface the cervix during that early labor time or before labor begins. Relaxin releases the cervix, ligaments, and connective tissue. So your provider's probably been telling you that you're just a little bit more loosey-goosey. Things are, you're more prone to falls and accidents during pregnancy because your ligaments and connective tissue are looser during pregnancy. It allows greater flexibility of your joints and helps the pelvis to flex and accommodate a baby during birth. Your pelvis doesn't just stay still. It can move, it can flex, and we'll go through lots of different ways that we can move the pelvis in labor. But just know that that does sometimes make you a little bit more clumsy. So during pregnancy, you want to make sure that you're being very mindful of that. If you are working out, if you're doing yoga, those kind of stretching, things like that, just be really mindful that we're not overstretching ourselves in pregnancy because of that relaxin. Oop, we skipped one. Okay, so let's talk about the 6 ways that we progress in labor. A lot of times, people only think about dilation in labor. Okay, I was 2 centimeters, then I was 5 centimeters, then I was so many centimeters. But there is so much more that's going on and so many more pieces to the puzzle of labor than just your cervical dilation. So I'm going to show you a little something with some Play-Doh here. So the first thing that our cervix actually does, and this is my Play-Doh cervix. It's about the size of my thumb, and as you can see, it's really thick and tall, just like you saw in those diagrams. The cervix is going to move from the back to the front. So from posterior to anterior, you're going to feel that. You're not going to feel it. If you get a cervical check, your midwife would be able to tell if your cervix is located in the back still or if it's moving forward. Then what the cervix is going to do is it's going to start to soften. So your cervix will start out feeling like the tip of your nose, kind of that a little squishy, but mostly hard tip of your nose. And then it's going to start to feel a bit more like your cheek. And then when your cervix is fully effaced and thinned out, it should feel like the inside of your cheek. So that squishy, really thinned out feeling on the inside of your cheek, that's what your cervix will feel like as you progress in labor. Then your cervix is going to do that effacement that we've just been talking about. So your cervix is going to move from this to start to move down and thin out. And this is going to happen sometimes in conjunction with your dilation. So you're going to start to thin and efface. And this is actually measured in percentages. So if you're choosing to get cervical checks, you would hear your provider say you're 70% effaced, right? So that means 70% of your cervix is nice and thin and starting to stretch out. And usually we'll hear like you're 70% effaced and 2 or 3 centimeters, right? So then you can see that that happens together in motion. So here we've started to dilate a little bit and we've started to efface. So that is going to be most of your labor, is that cervical dilation and thinning of the cervix until your cervix fits over your baby's head, right? So this is kind of what your cervix is going to do. It's going to pull up and over your baby's head as you dilate, okay? Until it's reached full dilation and your baby can descend down. Then your baby is going to, so your baby's going to be descending down. Then I've got my pelvis and your baby's going to rotate. So we'll go over the cardinal movements more during our pushing phase in class 3. But essentially your pelvis is wider at the top from side to side. And at the bottom, your pelvis is wider from front to back. So your baby is going to make a corkscrew motion to be born. So we'll go through more of that in class 3, but those are the 6 different ways that your labor progresses. It's not just about dilation, and we're going to talk later about how just because you're 10 centimeters doesn't mean it's time to push, all of those things, but know that it's so much more than just dilating. So a lot of times you'll hear things like, you'll hear 3 different numbers if you choose to do a cervical check. You'll hear the dilation number, right? How wide your cervix is. You'll hear that effacement number, which is a percentage, and then you'll hear where baby's station is. And we're going to talk about engagement and station in a few slides, but you'll hear a number either positive, -3, 2, 1, 0, positive 1, 2, 3. And positive 3 is like we have a baby. So just know that there might be several different numbers that your provider would tell you should you choose to do a check at any time, before or during labor. So here's another example and a good visual of that effacement. So as you can see on the left-hand side, we still have a mucus plug. The cervix is nice and thick, protecting the baby and the amniotic sac from the vagina, and not effaced at all. And then as they move through labor, you're going to lose that mucus plug, and that cervix is going to start to thin and stretch over baby's head. So when will you lose your mucus plug? I can't tell you that. Some women lose it during labor. Some women lose it, and that's kind of their first sign of labor. But it is a good indicator that some kind of change is happening. And sometimes you miss it, and it just falls into the toilet. So, okay, let's talk about engagement and station. In the final days and weeks of pregnancy, the baby is going to engage down into the pelvis. You might be feeling more discomfort in your lower back, more frequent urination, more pressure on the pelvic floor. You might be feeling a little bit unstable in your pelvis, but perks, it might be easier for you to breathe, having less heartburn, and the ability to eat more. A lot of times you'll hear other women tell you that you look like you've dropped. That's usually when your baby's kind of getting locked and loaded and ready for birth. So as you can see here by the diagram, like I told you, -3, -2, -1, and then 0 is actually at the ischial spines of the pelvis. That's when the baby is in here in the middle of the pelvis. And then +1, +2, and 3, we are like having a baby. Now, why is the station of the baby important? Well, it can impact the different techniques that we might do, or the different positions that we might do in labor to aid the baby in descending down through the pelvis. So if the baby is really high, we want to try to make the opening of the pelvis larger, right? So we might be doing really deep squats to open that top of the pelvis. If the baby is at that 0 station, we might be trying to do more asymmetrical things to aid the baby in rotating down through the pelvis. So we might be doing things like doing the stairs or doing lunges, different things that we're moving side to side so that we're moving that baby through. And then if our baby is nice and low and we're maybe pushing, then we want to try to open the bottom of the pelvis. We can do that by different techniques, different positions, like keeping our knees together and our ankles out helps open the bottom of the pelvis. So we'll talk lots more about that in class 2, but just know that that is a factor when we're looking at where we're at in labor and what we would like to do next. Variations in presentation. So a baby is typically born head down, chin tucked, just like you see in that first baby. So the next variation in presentation would be shoulder or transverse, as you can see there. So we can have a baby vaginally breech, we can have a baby vaginally head down, but having a baby vaginally through a shoulder or transverse lie is just not possible. It's just not going to fit through the birth canal. So in this instance, we would want to try to turn baby either head up or head down, preferably head down, before labor began. And we can do that. I'll show you a few different ways on the next slide of how we can make space for baby to try to get baby to turn. But if we do have a true shoulder presentation where baby just is going to stay in that spot, that would be another cesarean section birth. Another face presentation, or another presentation, is the face presentation or brow presentation. So typically with the head down baby, we see them tuck their chin to their chest, so that it makes the crown of the head here the presenting part, and that's the easiest way to have your baby. But sometimes our babies don't flex their heads chin to chest, and they kind of position their head out and present face first or brow first. This is just a much wider surface area to move through the cervix and the vaginal canal and to have. So this just makes it for a little bit more difficult of a birth. Then we have the 3 different variations of breech birth on the bottom part of our diagram there. So the first one that we have shown is complete breech, and that's where your baby's feet are kind of tucked up in maybe crisscross applesauce or kind of tucked cannonball style in the pelvis. Then you have a footling breech, and that's a baby that has one leg up, one leg down, and you would see like a foot come out first. And then we have the frank breech, which is your baby being like accordioned in half, and we're presenting a bum first. Both feet are all the way up. If we're going to do a vaginal breech birth, frank breech is actually the most preferred breech to have vaginally, because you have less chance of a foot coming down and kind of getting caught in that cervical area, and less chance of that dystocia happening. So what do we do if we get to the end of our pregnancy and we've planned an out-of-hospital birth and our baby is breech? Well, that is a very personal question and a personal decision for each person and their care provider. So the first thing you would want to do is make sure that you're having conversations with your provider about their comfortability with breech birth. Is it something they've trained in? If it is, how many breech births have they done themselves? How many breech births have they been witness to? Where I am here in Michiana, breech births just aren't done in hospital. There are no providers that I'm aware of that will do a vaginal breech birth in the hospital. They all schedule cesarean sections, and that goes to a long history of just losing the art of teaching breech. So there are some providers in our area that do continue to do vaginal breech birth, but most of them are out of hospital. In hospital, you'd be hard pressed to find someone that would do a vaginal breech birth there. So that's something to talk to your provider about and make a plan if you get to the end of your pregnancy and your baby isn't turning. But we're going to talk about encouraging optimal fetal positioning and trying to encourage our baby to be head down. So there's a few different ways that we can do that. Here you can see that the arrow is pointing to LOA, or left occiput anterior. So this is the preferred way for a baby to come down into the pelvis. It just makes for the easiest transition and easiest rotation through the pelvis. That doesn't mean if your baby's presenting other ways that they cannot be born. It's just this is like the preferred way to be. But there are also other variations of head down. So there's something called ROP or LOP, posterior baby. So that's a baby who is what we would call sunny side up. So that's when the baby's face is facing the mother. So the baby would be coming out face first instead of the back of the head first. So if the baby is coming out face first, their spine is also aligned with the mother's spine. This just tends to be where we see moms that are having like back labor or a longer, harder labor are usually those posterior babies. Again, it doesn't mean that we can't have a baby posterior. It just means that sometimes it's a little bit longer. So those are some different variations in presentation. And how can we encourage our babies to try to get into that LOA position, that head down LOA position? We can go to a place called spinningbabies.com. And that is a website that is a great resource with lots of different stretches and different things that you can do in labor to try and encourage optimal fetal positioning for baby. And in that are the 3 sisters of balance. And we're going to go over the 3 sisters of balance at the end of class today and kind of model those for you. But basically, the 3 sisters of balance are 3 stretches that take about 15 minutes or so that you can do daily in the end of your 2nd trimester, beginning of your 3rd trimester, to balance your body. So it starts off with rebozo sifting or belly sifting or jiggling. So if you have a placenta that's on the back, a posterior placenta, then you're good to do belly sifting, and that's where we wrap a wrap around your belly and jiggle it. Or if you have a placenta that's in the front, you could also do just jiggling instead. So you can kind of jiggle the booty and put the rebozo around the booty and do it that way. And then it goes into the inversion. So a forward leaning inversion would be where you have your knees up on like a couch, something that's not too far off the ground, but far enough that you're getting a good tilt. So you would have your knees on the couch and you would go down and put your elbows on the floor, booty in the air, kind of like this. And you would take 3 big deep breaths in, and then you would sit up and take 3 more big deep breaths. That's the forward leaning inversion. And then the last stretch would be the side lying release. So these are all done with a partner, are the easiest way to do these. With the side lying release, you lay sideways or you lay lengthways on like a bed, and you let one leg hang off, your top leg hang off, while someone holds you onto the bed. And again, I will demonstrate these and also have links in the email to show you examples of the 3 sisters of balance. But these are really important things to do towards the end of your pregnancy. Try to get them in at least once a day, just once a day. The other thing we want to think about as we are pregnant and going through this pregnancy is resting smart. So in our lives in modern day times, we do a lot of sitting, we do a lot of driving in a car. We're not up and active the way that our ancestors used to be. So we want to be really smart and methodical when we're thinking about the way our body is presenting itself and like the body mechanics. So one thing we really want to make sure that we're doing is sitting up straight. So we want to try to avoid leaning back. Like if you're resting and watching your favorite Netflix show, instead of leaning back in the lazy boy, we want to try to lean up. So we want to create kind of a hammock with our lower belly. We want to have our knees in line or lower than our hips so that we're not creating a slouching type of emotion. We want to try to make sure we're using really good posture. Now, your baby's back is the heaviest part of your baby. So if gravity is working with your baby inside of your belly and you're leaning back, what's your baby going to do? It's going to kind of swing and rotate so that it's chilling back to back with you. If you are up and using good posture, then your baby is not necessarily wanting to turn that way. If you are just trying to relax, because I get it, you are pregnant, you just want to watch Game of Thrones or something and chill out, that is fine. Just try to like lay down on the couch on your side, maybe with some propped pillows up, as opposed to like sitting back in a squishy couch or like a lazy boy recliner. Forward leaning position. So especially in this last trimester of pregnancy, just going into the kitchen and like leaning over the countertops and letting your belly hang, doing really good stretches like cat-cows, where you're on all fours, hands and knees, and you're kind of stretching your back up and down and doing a lot of breathing with that can be really helpful. Again, those forward leaning positions, if your baby's back is the heaviest part and we're hanging our belly, then your baby's more likely to turn to that LOA position. So making sure that we're trying to do that as much as we can in the end of our pregnancy. Walking every day is really good cardiovascularly, but also stretching and making sure that we're having a balanced body. We want to try to still have movement as much as we can. And then I recommend prenatal yoga to everybody. Not only does this balance your body with stretches and learning how to like stretch your psoas muscle and different parts of your body and making more room in your pelvis for your baby, but it also really helps with breathing techniques, learning how to do those really deep cleansing breaths, learning how to send those breaths to different parts of your body. But they also focus on mental preparation and really like learning how to relax your body and go from head to toe and really be mindful of your movements, mindful of your body in that pregnancy time. Okay, let's talk about contractions. So you may have already been feeling some Braxton Hicks contractions, depending on how far along in your pregnancy that you are. So we're going to talk a little bit about the difference between Braxton Hicks versus early labor. And we're going to do a fun little activity where I have, oops, hold on, accidentally sent us forward. So I have a balloon, and inside of the balloon, I have a ping pong ball. Okay, I apologize. I have some rowdy cats in the other room making quite a bit of noise. So now you have your uterus, and inside of it, you've got your ping pong ball, which is your baby's head, and you're going to go ahead and blow up your uterus. All right. So here you have your pregnant uterus. Remember, our uterus grows to the size of a watermelon, so we're not true to size here. But this will do for this demonstration. So here at the bottom, this is the representation of our cervix. As you can see, it's still nice and thick and not effaced yet at all, and we're not really dilated at all either. So when you have those Braxton Hicks contractions, a lot of times you'll feel them on the side, maybe on one side, maybe even both sides, but they're not really doing a lot for us as far as changes in the cervix go, right? The top of the uterus is called the fundus, and that's where the powerhouse of the uterus is. That's where we've got all those muscles that are going to push our baby down when we're in active labor. So you might be feeling, again, side to side, but we're not making a lot of change. This can even happen during what's called prodromal labor. So in class 2, when we talk about stages of labor, we'll talk about something called prodromal labor as well, which is kind of that before active labor hits. But then as active labor hits, you should start to feel your contractions more towards the top and wrapping around the entire uterus. So you'll feel that come down from the top. And as you can see, now we've started to efface. Now our cervix is starting to thin out, and we're even having a little bit of dilation. And as those big powerhouse contractions continue, they're going to continue to dilate. See, we see our little baby in there. And those are what are going to cause changes in our dilation and allow us to have a baby. And there you go. You have your baby. So that's just a fun little demonstration of the difference between those Braxton Hicks and those early active labor kind of contractions. Now, as your cervix effaces and thins, it's going to create more space at the top of your uterus, at that fundus. So the more it thins, the more powerful our fundus becomes, and the more powerful our contractions become that move our baby down. So let's talk about timing contractions and what that looks like, what that can look like. So the midwives that I work with recommend the full term contraction timing app. There's lots of different other apps out there as well, though, that you can get, or you can just do it the old fashioned way with pen and paper too. That's okay. Frequency of contractions is time from the beginning of one contraction to the beginning of the next contraction. So we can see here on our diagram that our contraction begins at that 30-second mark, and the next contraction begins at the 5-minute mark, meaning that our contractions are about 4.5 minutes apart. Duration is time from the beginning to the end of a contraction. So again, we start at that 30-second mark. We can see the contraction peak and come down and end at that 1-minute mark. So that means that these contractions are 30 seconds long and 4.5 minutes apart. Both times have significance as we want to see contractions become longer, stronger, and closer together. In early active labor, your contractions will probably be between 30 seconds and 1 minute long. And then sometimes as labor progresses, contractions can even get to be 90 seconds in length as well. We'll break down how to gauge where you are in labor by the length and strength of your contractions during class 2 when we do stages of labor, but this is how we time them. Now, when it comes to timing contractions, definitely talk to your provider and see what kind of information they need. Specifically with out-of-hospital birth, we're trying to time when you want to start heading towards the birth center or when it's time for your team to come to you. We're going to talk in a little bit about physiological labor and the environment in which fosters the best results for physiological labor. Basically, the saying goes, a watch pot doesn't boil. So we don't want to call our team in too early and have them kind of as a distraction to you, but we also would like them to get there before you're in transition. So there's kind of a fine dance of when you're going to want to call your team to join you. But what we don't want to do is obsess over timing contractions. You don't need to time every contraction from the beginning of your labor to the end. A really good rule of thumb is that if you feel a shift in your labor, time again. So if you're starting to feel like, this feels different than the Braxton Hicks, this feels different than that prodromal labor, I'm laying down, I'm drinking a glass of water and they're not going away, I think this is early labor. Great, time some contractions, maybe half an hour or an hour of contractions, and then get some rest, do your life, go back to life as normal until you feel a shift in your labor. And then once you feel that shift, you're like, they seem to be coming faster. They seem to be a little bit stronger. Then do another chunk of timing, that 30 minutes to an hour, check in with your team, and then again, go back to life until we can't ignore it anymore and you're feeling like you're ready to call your team. Let's talk about the elements of a contraction. So contractions are a lot like mountains with peaks and valleys. The beginning of a contraction is what I call the build. Practice your relaxation as the contraction builds to the peak. So this is a really good time to take really deep cleansing breaths and prepare yourself for the peak of the contraction. What we want to try to avoid is tensing up during the build because you're anticipating the peak. So we want to try to stay away from like tensing every muscle in our body. And instead we want to relax from the head all the way down to the toes, keeping nice soft shoulders, a nice soft jaw, and really leaning into the build of our contraction, creating those big, deep breaths in our chest. The peak happens during the middle of the contraction. This is around the 30-second mark of the contraction. And this is where your coping techniques can be really helpful and an outlook that you're halfway there. You only have to do 30 more seconds or 60 more seconds of this contraction. And this is the hardest part. So this is when things like counter pressure, pressure points, movement, noise, if you're later on in your stages of labor, hydrotherapy, visualization, all of these things can be really helpful during the peak. We still want to try as much as we can to stay nice and relaxed and loose in our body, but this is kind of the hard part of that contraction, a very short time in that entire contraction time. Then you have the descent. And the descent is where you breathe away the intensity of the contraction and start to come back down. What we don't want to do is live in the peak, okay? So as soon as that peak is gone and you're starting to feel yourself come back down from the contraction, again, big, deep cleansing breaths and try to let it melt away from you. And then in between our contractions, that time in between, rest is really, really important. Unless we're like eating some food quick or going to the bathroom or changing positions. But for the most part, we want to try to rest in between contractions. A lot of times we'll see moms later in labor. So as we're getting to that like transition-y, getting close to pushing or pushing time, we'll even see moms take like micro naps in between contractions where they'll just for those like 2 or 3 minutes, they'll take a little snooze and maybe even start to snore. That's great. We love to see as much rest as can happen in between because you are using so much energy and burning so many calories during the peak of those contractions. We want to try to not waste energy in between the contractions. So partners, this is also something that you can really help with is bringing them back down and making sure that we're letting them rest in between contractions. We're not chatting too much. We're not distracting them. We're like making sure that they're taking their rest in between. Also, when we talk about contractions, as far as like outside people, the birth team or partners, it's really important for us not to distract you during your ritual of your contraction. So a lot of times there'll be something called the 3 R's: rhythm, relaxation, and ritual. And women who utilize these 3 things and you find something that you do with every contraction, whether that's swaying back and forth, whether that's making a certain noise, whether it's holding onto a comb, like you see in this picture here. This woman's using a comb for acupressure to help her get through her contractions. Whatever it is, you'll have a ritual that will present itself, and it's our job as the doulas, as the partners, as the team to make sure that we're not interfering with the coping mechanisms that are working for you. We're also not on our phones. We're not chatting about Six Flags. We're not being distractions. We are there and we're focused on you. Okay. So moving towards an acronym that I really like, a lesson that I really like is called the Happy Uterus Lesson. And it's an acronym for a smoother, more pleasurable birth experience. This acronym was actually coined by Cami Schwartz. She's a birth doula and childbirth educator here in New Paris, Indiana. So we want to break down the word uterus, and we've got different words for each of this, and it's going to create foster a great physiological birth environment. So the first element is the U, and it stands for understood. It's an important element in preparing for your birth. You want to feel on the same page with your provider and your birth team and feel understood by your provider and your birth team. You also want to know that your provider has an understanding of the birth process. And I'm sure you're thinking, well, of course they have an understanding of the birth process. They're an expert. They're an OBGYN. They're a midwife, etc. But do they have an understanding of the type of birth that you're wanting? Talk to them about, what their philosophy in birth is, what a typical birth looks like. Have them run through a typical birth with you and what that looks like. Do they always give Pitocin postpartum? Do their clients always push on their back? Do their clients always deliver in a certain way? Do they always break their clients' water? Things like that. Those are important things to know so that you're knowing what type of birth you're signing up with your provider. OBGYNs are actually trained surgeons, and they are very skilled in that. And we are very thankful to have skilled surgeons should we need a cesarean section, but they have less training than midwives do in physiological birth, and they see a lot less of physiological birth. So one example, like when you think about something like this, is you wouldn't necessarily hire a race car driver to take you for a casual stroll through the countryside. And you also wouldn't hire like a Ford Model T car to take you to drive in a NASCAR race, right? So it really depends on the type of birth that you're looking for, the type of provider that you want to have. And then making sure that that provider understands the experience that you're looking for, understands the background from which you come, understands all of the reasons that you're making your choices for that birth. Those are really important pieces to the puzzle too, so that you can foster a good relationship moving forward for this birth. Understanding the process of birth also applies to the mom and the partner. So it's important for you guys to have an understanding of how the mechanics of birth work, which is what you're doing right now. Great job. To help you envision your experience, to release fear from the process, and also help you make choices when those variations come, to fruition, or if they come to fruition, for you to make informed decisions. Excuse me. So the T in uterus stands for tension free. Our bodies have something called the fight or flight response. We're fight or flight mammals. This means that when we're scared, we as humans immediately hold tension and blood flow in our outer extremity, like our legs for running or flight, or our arms and our hands for fight. So think about if a lion burst through the door right now, your body would have a physical response, sending blood flow to your arms and legs so that you could either run out the door or fight off the lion. Well, during birth, if we have a feeling that we're afraid or in danger, our body's response will be the same, because it can't differentiate between a lion and just being afraid in labor. This means that blood is being pulled away from your core, and it's being pulled away from your uterus and into your outer extremities. And it also creates tensions in your hands, your shoulders, your face. This in turn creates a more painful and less effective contraction, because we're pulling blood away from the uterus, so it's not able to have as much power. Then the cycle continues. The less you're able to cope with the contractions, the more fearful you become, and the more tension manifests in your body, and then the cycle just continues. So how do we become tension-free, and how do we break that fear, tension, pain cycle? Well, we can do some guided meditations, and your partner can help you with this, or you can always listen to like Hypnobaby's birth tracks or different birth meditation soundtracks as well. But really moving through when you're feeling anxious, you're feeling that tension in your body, we want to try to make sure we're not, again, tensing up all of our muscles. So we want to move from the top of our head. We can close our eyes, move from the top of our head, and really focus on relaxing every muscle in our body when we're in between a contraction. So we'll start at the top of our forehead, release our forehead, move down to our eyes and release our eyes, move down, try to release your jaw, release your tongue, let everything be soft, and move down through our body, through our shoulders, move through the arms, the hands, move through our belly, and really focus on meditating and going all the way down through the body in between contractions, and then really using all of our coping skills to continue that as that peak starts to build, right? So really relaxing our entire body through that contraction and trying to stay as loose as we can will really help break that cycle. The E in uterus stands for energized. And so when we talk about energized, part of that is nutrition and calories. So it takes about 3,000 calories to birth a baby, which is insane. We want to continue to eat and drink as you wish during your labor, during that early labor time. Make sure we're having a good meal before labor begins. You can do things like Labor Aid or like Gatorade, some kind of an electrolyte drink during the birth, and then also making sure you have lots of different snacks. If you're going to the birth center, you're going to want to pack those with you. If you're staying at home, you want to make sure that they're ready to go in the house so that you've got things like little cheese sticks or little granola bars or power bites, or you can do like fruit. You want to have a variety of things because some things just will probably not seem appealing to you. Based off my own experience, I would urge you to avoid fried foods. Doesn't go well towards the end of your labor. So try to keep things light, keep things nutritious, and make sure that we're fueling our body with good stuff during labor. And then also, just as a side note, making sure we have a good meal planned for the immediate postpartum as well. Also, when it comes to energize, we want to make sure we're resting as much as we can. We want to try not to overwork that early labor time. And really, we want to try to be getting in as much naps and resting as we can from that 37-week time on, to when we might be having a baby, and make sure that we're well rested in preparation for labor. A lot of times you'll be very excited, especially your first time around. You'll be very excited that you think maybe you're in early labor, maybe you're having contractions every 8 to 10 minutes, something feels different, and you'll call your team, and your midwife will probably be like, "That's amazing, go to sleep." We want to make sure that we're conserving as much energy as we can before the big show, the big time, and when labor really starts getting active. So resting as much as we can and not overworking it. If it's the middle of the night and you can sleep, please do. So just make sure that you're listening to your body and not, I know it's very exciting, but try to go back to sleep if you can. So the R in happy uterus stands for ready. When we talk about being ready, we're mostly talking about waiting for labor to begin on its own. Due dates are calculated by taking the date of the first day of your last menstrual period, adding 7 days, and then adding 9 calendar months to that day. But there's a lot of different nuances in that, and it doesn't necessarily account for women who ovulate early or late in their cycles. It doesn't necessarily account for when you had intercourse to become pregnant, those kinds of things. An early ultrasound can also be a way to calculate a due date as well. If you're unsure about dates or if you've had irregular periods, The earlier the ultrasound, usually the more accurate the date. So, and typically if we're moving in, like, let's say we're at the 20-week mark of your pregnancy and you get your anatomy scan, if your estimated due date is off by a couple days, they typically won't change it. But if it's off by 2 weeks or more, then they might start looking at changing an estimated due date for you. Less than 5% of babies come on their actual due date, and a normal pregnancy is anywhere from 37 to 42 weeks. That's considered term. That is good to go for out of hospital birth. Most first-time moms will go 5 to 8 days over their due date. So try not to get wrapped up in the idea that you're going to have a baby by the time that that date comes. Yes, we want to have things prepared by that 37-week mark, especially for home birth. We want to make sure we've got our home birth kit ready. But try not to fixate on the fact that you're going to have a baby before that. Try to think of it more as a due month, and maybe don't tell friends and family the actual day to avoid any well-intentioned annoyance. Usually by the time that day comes, you are over it and ready to have a baby and ready to meet your baby. So 30,000 text messages asking, have you had the baby yet, can sometimes get really stressful and add more stress to the end of the pregnancy that's not needed. So you can be just like a celebrity and just say, I'm due in the spring. And then people will know when it's time and when you've had your baby. You're not going to sneak attack a baby and not show them until they're 2, you know. So just making sure you're having this conversation with friends and family of not pressuring you. Your body will go into labor when it is ready. Your baby will signal those hormones for labor when they are ready, when their lungs are fully developed. That's what triggers labor to begin. So waiting for baby as much as we can, as long as everything is normal and as long as we don't have any outlying factors, is the best way to go. So sometimes that means we're waiting until 41 weeks, 42 weeks to have a baby, and that's okay. Okay, the U in happy uterus stands for undisturbed, uninhibited, and unleashed. So when we are thinking about our birth space, we want to try to make sure that we're utilizing 4 things that mammals need for successful labor. That's privacy, silence, darkness, and warmth. Now, don't get me wrong, you don't have to have an absolutely silent birth, but we want to avoid like really loud noises, beeping, outside chatter, focused things that the mother wants during the labor. That's what should be going on in the room. So privacy, just like we talked about a little bit ago, the watch pot doesn't boil. What you don't want is a bunch of people just staring at you in the room. As you continue in labor, you're going to have different brain wavelengths that we're going to talk about. But when you're in that early stages of labor, any like outside force can kind of throw things off and make you maybe trigger that fight or flight response, maybe trigger that fear, tension, pain cycle. So we want to try to keep you as undisturbed as possible. And then darkness, again, it doesn't mean it has to be pitch black where you're giving birth. But when you think about, like I grew up on a farm and we had barn cats. And if a barn cat was going to have kittens, she wasn't going to have the kittens out on the middle of a sunny day in the barnyard. She was going to wait until night. She was going to crawl up into a dark, warm drawer, and she was going to have her babies in a drawer somewhere where they were very hard to get to afterwards. But she craved that silence, that darkness, that alone space, and that warmth. So trying to make sure that your environment kind of mimics that as well. So nice low lights, try to keep the overhead lights off. But you can have like little lamps, or maybe you have LED candles that you can bring with you to the birth center or set up at home. At home, I would strongly encourage you to like create your nest before labor begins. So maybe you have a birth affirmation cards that speak to you. Maybe you have baby's ultrasound up there, or you've got twinkly lights set up. You've got things that really let you envision what your birth is going to look like. And you can set those up in that 3rd trimester and really get into the mindset of this labor and having a peaceful, calm environment in which to bring your baby. And you can also replicate that at the birth center. Bring those candles, bring those birth affirmation cards, make it dark, make it quiet, like a little birth cave. And that will be really helpful in fostering those hormones and fostering that oxytocin flow as well. Okay, the last letter in our uterus is S, and that stands for supported. So that doesn't just mean physically, but it also means mentally and emotionally supported. When mom is in labor, all of the attention is on her. Even if a woman doesn't end up wanting to be touched in labor, which very well may happen, you might not have to bust out those hip squeezes. She might not want you to touch her. We can still support her emotionally and mentally by being by her side during this really hard work. Our focus and attention should be on her whenever we're in the room, and side chatter should be kept to a minimum unless it's something that the personality of the birthing person wants. So when you think about these things and you're planning where and with whom you're going to labor and have your baby, what kind of environment do you envision when you think of these words? How can we bring these adjectives to other locations and make the hospital or the birth center feel like our own homes? Also think about the people that you're inviting to the labor. Do you feel able to be completely unleashed and uninhibited with them present? Will these people be able to adapt to the tone of calm, quiet, and safety during this exciting time? And are they adding to your space or taking away from it? So when we look at the word supported, maybe you have a sister or a cousin or a mother-in-law or a mother who really wants to be at your birth and has been asking you to be at your birth. That is not a reason for them to be at your birth. And that's not really a support person for the birthing person or the partner. A support person is something that the mother craves and wants to be there and really like has a job. And sometimes that job is that emotional support. But if it's someone that is just there to sort of watch the show, that's not someone that necessarily needs to be in the room or is going to help you foster that good oxytocin flow. Remember, you're going to be in your most vulnerable state ever, and you're going to be naked, you're going to be in different positions, you're going to be in a completely different state of mind. So keep that in mind as you're thinking about inviting people to your space. Well, and also think about, what is their experience with home birth, and are they comfortable with home birth? Are they comfortable with out of hospital birth? All of these factors play in, and we'll talk a little bit more about that at the end of class as well. Okay, let's get into nutrition during pregnancy and the Brewer diet. Okay, the Bradley Method of Childhood recommends Dr. Brewer's pregnancy diet to help prevent preeclampsia, hypovolemia, anemia, and any other deficiencies for you and your baby. And the midwives that I work for strongly encourage it. So Sacred Journey Midwifery, this is the nutrition plan that they also go over with you. The Brewer diet consists of 14 food groups, which a mother can choose from daily or weekly. However, the diet can be summarized as having 4 basic components: 2,600 calories a day, 80 to 120 grams of protein, salt to taste, and unrestricted weight gain. The specifics of the diet have been compiled by Dr. Tom Brewer, an obstetrician, after years of studying the research and information available since 1929 on the effects of nutrition in pregnancy. He has been able to see his philosophy used to prevent and treat various complications of pregnancy, including that elevated blood pressure, edema, so swelling, preeclampsia, eclampsia, toxemia, gestational diabetes, premature labor, anemias, abruption of the placenta, intrauterine growth restriction, and low birth weight, which can cause babies to be infection prone. All of these problems have a common source: food deficiency and low blood volume. Your water intake should be about half of your body weight in ounces. So if you weigh like 150 pounds, then you'll want to drink at least 75 ounces of water. Salt can actually help you stay hydrated and lower your risk of preeclampsia. So that's when you have elevated blood pressure in pregnancy. If you're not dousing your food in it and just adding it to taste, you don't have to add it. Just make sure that you have enough sodium that your system, that you're lucid and not dehydrated. So again, you can use that like Labor Aid electrolyte drink. All right, let's talk about protein. It's very important because it supports tissue growth. Back to those amino acids, they have an awesome nickname that you should remember called the building blocks. Why? Because when you are having to eat so much protein, 80 to 100 grams, which is a lot, remind yourself that you're giving your child the building blocks for a better health, nutrition, and development. So again, that 80 to 100 grams of protein, you can get that through chicken, fish, lamb, beef. If you are not a meat eater, you can do tofu, peanut butter, peanuts, sesame seeds, eggs, which we're going to get into eggs by themselves in a little bit, and how wonderful they are. Cheeses, brown rice, and a variety of other ways too. But you want to try to get a protein in with every meal and every snack if you can. 80 to 100 grams. Calcium helps build strong bones. If the pregnant mother does not get enough calcium in her diet during pregnancy, the baby will actually leach it from your bones. So we want to make sure that we're getting in at least 4 servings a day. And that can be like your traditional milk, cheese, yogurt, etc. Or you can find it also in almond, kale, broccoli, black olives, sardines, all of those places as well. So making sure that we're getting a nice amount of calcium. Eggs. I told you we'd come back to eggs. The suggestion is 2 eggs per day, the whole egg, whites, and the yolk. The egg is really the most wholly nutritious food that you can eat. It has almost every vitamin and mineral that you need. In fact, it has amino acids that are necessary for proper metabolism and that influence and help you synthesize the protein that you're eating. Eggs even contain essential amino acids that affect your baby, yours and your baby's neurotransmitters. It also includes vitamin A, which has many healing properties. So we want to try to make sure that we're getting in 2 eggs a day anyway. Dark green veggies, 2 servings a day. Spinach is actually great because it contains folic acid, which aids in neural development, and you can blend it into smoothies. So these greens will help in digesting the protein of your diet and typically are a source of calcium too. Dark green veggies, try to get 2 servings a day. Okay, healthy fats, 3 servings of healthy fats a day. And why do we need to implement these fats? Well, some of the vitamins that we're eating and ingesting that we need for our pregnancy and for our diets are actually fat-soluble vitamins. And those are vitamins like A, D, E, and K. So those help us ingest our vitamins. So you can do things like avocado, real butter, mayo, olive oil, peanut butter. You're getting your protein with the peanut butter too. Ground flaxseed is really great. You can sprinkle a little bit on your oatmeal in the morning. Walnuts and salmon is a really good way to get those healthy fats. Vitamin C helps manufacture collagen. It's responsible for holding tissue together, and this helps us as humans build muscles and function properly. In fact, collagen is one of the most important and abundant components of your cardiovascular system, and it also aids in immunity and overall health. So we can find it in our traditional like oranges, grapefruits, tomatoes, but you can also get vitamin C in strawberries, papaya, green pepper, and potatoes. So 2 servings of that. Also, making sure we are getting enough vitamin C can help strengthen our amniotic sac as well, which will aid us in avoiding premature rupture of membranes, which we'll talk about in the next class. Okay, let's talk about birth planning, the first step to informed decision making. So let's talk about your provider and how you chose your provider. What makes a good provider? What are aspects of your provider that are really important to you? So what you and your partner can do right now is kind of write those things down or discuss them. What are some aspects that make your provider someone that you want to give birth with? How did you choose them? Is it because all of your friends chose this person, or did you actually do an interview with this provider? Have you asked them questions about their philosophy on birth? Their normal protocol with birth, how many births they do a month, where they have births happen, what their transfer rates are, etc. Those are all really important things to ask a provider. It's also really important to note here that you are not married to your provider. So if at any time during your pregnancy, you're feeling like you're not a good fit or you'd like to change your mind, you can always do that. You can always shop around for another provider and another birthplace as well. So when it comes to the birthplace, what things are important to you and your partner about that location? What were the determining factors in this pregnancy that brought you to, for instance, choosing the birth center over choosing home? What makes you feel safe? What environment makes you feel safe? If you're feeling stressed about the place where you're going to give birth, that again is going to trigger that fight or flight response. So we want to make sure that we're paying attention to those feelings, and we're really choosing the place that our instincts tell us is the best place to be with the best provider that we choose as well. So who will be invited to your birth and why? And we're going to focus specifically on this out-of-hospital birth. So provider in that pink column, you'll either have, when you're doing an out-of-hospital birth in Indiana, you'll either have a CNM, which is a certified nurse midwife, or you will have a CPM, which is a certified professional midwife. A certified nurse midwife goes to nursing school first and then gets a master's degree in maternity care. So she does that person does the nursing school first and then specializes in labor and delivery afterwards, and they can practice in hospital or out of hospital or at birth centers. A certified professional midwife is someone who specializes in midwifery, so they go to school just for midwifery. Laws get a little trickier in Indiana when it comes to certified professional midwives. Some of them can practice in the state of Indiana, but they have to have specific licensure to do that. So just making sure that you're talking with your provider, finding out what their credentials are, making sure that they are licensed in the state in which you're going to be giving birth. They help guide you through labor. They handle variations of normal and emergencies, and they provide informed care. So your provider is going to handle all of the medical side of your birth. They're going to be taking your blood pressure. They're going to be checking your temperature, checking on baby, taking heart tones for baby, all of those type of things. They're going to be doing all of your prenatal care and your postpartum care as well. What they might not do as much of is emotional support. So yes, midwives are going to support you emotionally through your pregnancy, but when it comes to the actual time of your labor, that's when something like a doula would be really helpful, so that we are making sure we're using our provider in the time and space that is optimal for them, so that we're getting them as much rest as we can in between labors. Also, it's important to make sure that we are giving them the space and the brain space to focus specifically on the science of your labor and really think about, like, okay, what is happening next? What do these heart tones look like? What does this blood pressure look like? And really looking at those type of things. Then you'll also have an assistant. So a trained professional, and this might be an RN. So if you're at the birth center, you'll probably have a registered nurse as your assistant. They aid the midwife. They may be taking vitals if they're an RN. If they're not an RN, they won't be taking vitals at home. They chart for the midwife, so they're the ones writing down all of the charting and things like that. Help with labor support, and they also help with setup and cleanup. So again, this person is more in that right brain type of thinking during the birth. They're helping the midwife should the baby need any type of resuscitation or help in the postpartum time. The assistant would be there helping the midwife fulfill those roles and working on those kinds of things. At home, the birth assistant will be doing like cleaning up the tub. Double check with your midwife that they do that. They should be doing that for you. The assistant will be like cleaning up the tub, wiping down all the surfaces, getting your home back into order, putting a load of laundry in. The goal as an assistant, from my practice, is that we want to try to make it look like we were never here. So I want to make sure that I'm leaving your home nice and clean while the midwife tends to you in that postpartum time, taking vitals and watching baby and things like that. I'm helping her, but I'm also cleaning up the space as well. And same thing at the birth center, they would be in charge of doing all of that as well. Then you have a doula. So a birth doula or a postpartum doula is a hired professional to help support you during pregnancy and labor. Typically, they'll arrive earlier in your labor than your provider might arrive. They work for you and not your midwife or any provider. So the great thing about a birth doula is if you would need to transfer it at any time during your pregnancy or during your labor, your birth doula would be the constant with you. So sometimes if you're transferring from out of hospital birth to in hospital birth, you're typically transferring to now an OBGYN or a midwife that's in hospital and out of the care of your out of hospital provider. So the doula can help bridge that gap. So let's say you develop preeclampsia and you need to go into the hospital for an induction and the plan changes. Your doula would go with you and support you in the hospital as well. They're the ones that are going to be doing a lot of those labor techniques with you. They meet with you in the prenatal time, teach you a little bit of birth education, help you figure out a birth plan, also help you with coping techniques. And they're the ones that'll be doing like hip squeezes for you and helping you find positions and those kind of things. And they're also supporting you emotionally as well. You've fostered a relationship during your pregnancy, and now they're there to help emotionally support you during the labor as well. Family and friends. So like we talked about a little bit already, have an open discussion about the expectations and roles. Don't leave this talk until you're 38 weeks and all of a sudden you have to tell your mother-in-law that she's not invited to the birth. Don't do that. Try to have open discussions and expectations leading up to the birth so that there's none of that stress leading into the birth time. And how is this person adding to your birth experience? Again, if we're saying things like, I think it'd be really good for my sister to see this, that's not necessarily a reason. Your sister needs to be there for you because you want her there, and that's fine. Discuss with this person their experiences with physiological birth and their comfort level with it. Maybe they aren't interested in coming to an out-of-hospital birth. And if we're going to have someone that like sits in the corner and does this the whole time, that's not helpful. And that's going to throw you off and throw off your labor pattern. So just making sure that we have people that are feeling comfortable with the experience. And I think a really good way to test whether or not someone is a good fit for your birth space is asking this person if they would honor your decision not to have them there. So if anyone's response to you saying, you know, I think I just want it to be me and my partner and the doula, so sorry. If their response is anything other than, oh, absolutely, I totally understand. This is your birth. This is your time. You just let me know whatever you need. I can bring a meal afterwards or something like that. If it's anything less than that, maybe they weren't meant to be there and maybe they wouldn't be adding to your space. If they feel offended by the fact that you don't want to birth a child in front of them, that's not really a reason to invite someone into your space. So just making sure that we're having those conversations during the time and that we're being open and honest. And yes, a lot of partners want to have their friends or family with them. But ultimately, it comes down to the birthing person should be able to make the decision of who is invited into the space. All right, let's talk about informed consent versus informed choice. Did you know that there's a big difference? So informed choice is when a person is given options to choose from several diagnostic tests or treatments, knowing the details, benefits, risks, and expected outcome of each option. Informed consent is when a person agrees to test or treatment that they have been offered, knowing the details, benefits, and risks of the expected outcome of that one test or treatment. So informed choice is having like a buffet of choices presented to you and being able to choose what you want. Informed consent is being given one filet mignon and that's it. So you can choose it or not, but not knowing that the back kitchen can make a whole lot of other choices, a whole lot of other meals for you. There's a big difference between informed consent and informed choice. And informed consent can give you tunnel vision. It can make you feel like you don't have any other choices. If a provider comes to you and says, well, you're 8 centimeters and we need to break your water, but doesn't offer you any other choices of, or we could wait, or we could try these positions, or we could do this instead, then you feel like it's break my water or nothing, or like not have a baby, you know? You don't have any other options if they're never presented to you. It's not enough to be told the benefits and risks. You also want your provider to tell you about all of the alternatives as well. Okay, let's talk about 3-talk model shared decision making. So we've got this nice little cycle here that helps foster good patient and provider relationships. So you've got team talk. You and your provider work together. Your provider describes choices, offers support, and asks about your goals. That's a really important aspect of this as well. It's not about them, it's about you and what you want for your birthing experience. So giving you all of those options. Option talk discusses all of the alternatives and the risks and benefits of each without interjecting personal opinion or judgment. Both of those are really important aspects of this as well. So you get all the facts and the facts only, and then you get to make your decision. Decision talk. You get informed preferences and your provider respects the choice that you have made without judgment or personal opinion. Now, this does not mean that we're throwing away their experience and not asking them. It doesn't mean you can't ask your provider's opinion or anything like that, but your opinion on the situation should definitely be a factor when you and your provider decide what's best for you. It shouldn't be your provider deciding what's best for you and you just saying yes. It's impossible to know everything about labor and birth and every possible eventuality that may occur during birth. It's unrealistic to expect expectant women to learn and retain knowledge about birth, all knowledge about birth, potential birth scenarios, and every choice relating to those scenarios. Even if that were possible, during labor, the neocortex is suppressed, making it difficult to access and intact rational knowledge. So it's very hard for you to make those decisions when you are in the throes of labor. It's more helpful for women to know how they want to be supported should they be required to make those decisions about unexpected situations. So it's manipulative to walk into a scenario where a woman is, really far in labor, in that like active transition phase, and then start bringing up things that you guys have already discussed you don't want, like saying things like, well, it'd be a really great time to get an epidural or something like that. That it's just manipulative to do that because you are on a whole nother wavelength. Your brain is on a whole nother wavelength, and your neocortex is suppressed. So knowing that you and your partner have decided on these things beforehand can be really helpful. Again, that doesn't mean that we are set in stone with the birth plan and we can't deviate from that and that you can't make different choices during labor. You absolutely can, but making sure that your provider is really supportive of the birth experience that you want and helping you achieve your vision. Okay. Let's talk about the BRAIN acronym. It's one of my favorites, and we'll be wrapping up class here after this slide. But BRAIN is a tool that you can use and your partner can use in any birth scenario, in the hospital, at home, at the birth center. Whenever we're looking at making a decision about something, we can use the BRAIN acronym. So we'll ask, what are the benefits? What are the risks? What are the alternatives? What does your intuition tell you? And what happens if we do nothing? So let's say, for instance, the midwife is suggesting that you could take castor oil to make labor speed up or to start labor. Let's say, your post dates, you're feeling like you've had prodromal labor on and off for a few days, and the midwife's like, hey, why don't we take some castor oil and it'll be a natural induction method for you. Well, that would be a time where we want to stop and say to ourselves, okay, well, what are the benefits if I take castor oil, right? Midwife, give me all of the benefits of that. And I'll just tell you the benefits are that you might go into labor. What are the risks? What happens? What are some of the adverse things that can happen from taking castor oil? What are the alternatives? So what could we do instead of that? Again, giving us all of those choices instead. So are there anything I can do besides taking castor oil? What does your intuition tell you? So really listening to that gut and going with that as well and factoring that in. What do you feel like is the next right step? And what happens if we do nothing? So can we just wait a while? Do we have time? A lot of times, unless it is a true emergency and we're moving fast, you'll have time to make decisions and you can have time to slow down and make a choice. And also asking for time alone when you want to make that choice as well. So having a provider, offer you a choice like the castor oil, or let's say, hey, you've been laboring a really, really long time at home and the midwife's offering you a transfer for therapeutic rest or something like that. you can ask like, okay, give me all the benefits and risks and alternatives, and then we would like a few minutes alone to discuss it. So that you don't have to make a decision on the spot with your provider. But this brain tool can be really helpful in literally every aspect of your life, but especially for pregnancy, labor, and birth, and bringing with that with us to the birth space. And it's really easy to remember. Just remember the little brain light bulb. So, all right. So attached to your email, you'll have a home birth plan template located in your resource file. And having a backup. So this home birth plan is great for home and for birth center. And then I also recommend having a backup birth plan in case of transfer for the hospital, and a really great website that has an infographic birth plan that you can put together is mamanatural.com. And next class, I was going to say next week, but you can take next class whenever you'd like because you have it downloaded. Next class will be going through all of our different scenarios that we might want to put on our birth plan, so we can help fill that in with the next class as well. Okay, so these are those 3 balances that I had mentioned earlier. Number 1 is that jiggle. And you just want to do that until you're feeling nice and loosey-goosey, like a couple of minutes. You can do the belly sifting as well, where you put a long piece of cloth over your belly, and then you're on hands and knees while a partner just gently jiggles your belly back and forth. And then number 2 is that forward leaning inversion. You can see there that the birthing person has their knees up on the couch and then elbows down on the floor. We don't want to go too far. Like if you have a very high bed, we aren't getting crazy. That right there in the photo is about as high as we want to go. And you want to make sure that you have someone there to support you during this. Please don't do it while you're home alone. Your center of gravity is off from having a baby in your belly. So I know you can do it, but please wait until someone's home with you. And again, you want to take 3 big deep breaths in, and then you would sit up on the couch on your knees and take another 3 big deep breaths. Okay, and then you can see number 3 is that side lying release, and the person is lying on their side on the bed, and they have a support person there holding their hip so that they don't fall off of the bed. You want to get uncomfortably close to the edge of the bed while still being supported so that your belly is hanging just a little bit off the edge. You want to keep that bottom leg nice and straight. You want your shoulders stacked on top of each other, hips stacked on top of each other, and then you let that top leg hang down in front of you. And you're going to do this just for a couple of minutes on each side until you can kind of feel that leg give just a little bit, and you'll feel maybe really tight on one side versus the other. That's normal. We want to try to lengthen and strengthen each side, and you want to try to stay in that position until you feel that little bit of give, and you should become more and more flexible with each. It's going to take a little bit of time. You're going to do this for weeks or months. So just making sure that we're getting that in as well. And that's going to create more space in the pelvis for the baby to get into that optimal fetal positioning. So we're going to do this every single day. There's also on spinningbabies.com, there is a daily essentials handout, which is really great, that can be linked in your email as well. And that kind of goes through all of the different things you can do on top of this. These 3 balances take 15 minutes. So if you don't have a lot of time in your day, making sure we at least get these 3 in. But if you can get in all of the daily essentials, that is wonderful as well. Okay, I also want to show you that there's going to be a birth video linked in your email as well. This is a birth center birth of Michael Lee. It is beautiful. So I really encourage you to take a look at that and take a look at some positive birth stories. Another thing that you can do to prepare yourself is listen. If you're a podcast person, you can listen to the Happy Home Birth podcast is a really great one for lots of positive birth stories through your headphones. YouTube has a lot of really positive home birth stories as well. I'll be sending a link for a video in each one of these classes. So if you don't want to go looking for them, they will be coming to you, but I highly encourage you to watch those as well. And that's it for class 1. I will see all of you for class 2. In the meantime, Have a great week.